Hello and welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and I'm on a mission to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be talking about neurology, we'll talk about MS, health and wellness, and we'll even throw a little bit of music and music therapy in there as well. Thank you all so much for joining us, and stay tuned for the next episode. Happy Monday and welcome to Brain Chat, friends. It is Dr. Mitzi, your board certified neurologist. I am so excited to be here with you guys on this wonderful Monday, pre-Labor Day holiday Monday night. So we have got an action-packed, exciting episode coming up today. We're talking about MS in the Hispanic, Latino, or the Hispanic Latinx community with some of my favorite nerdy neurologists, Dr. Lilyana Amezuca, and hopefully Dr. Chinea will be able to join us, but he's running a little bit behind, so we'll hopefully have him join the podcast as well tonight. So you guys know how we do when we get started on Brain Chat. Put in the comments where you are logging in from. I bid you greetings from Atlanta, GA, where we've been having a lot of rain and it's been kind of dreary, but we're still excited about the talk that we're going to have tonight. So put in the comments where you're logging in from. I see somebody from the ATL, a fellow AT alien. Hopefully our friends and colleagues in Louisiana are safe with Hurricane Ida. So definitely praying for them, for those who evacuated and those who are there, that everybody's safe. We also have some people logging in from Springfield, Missouri, Anderson, South Carolina. And if you want to, put in the chat what you're going to do for the holiday weekend. I am going to try to do nothing. So we'll see how that goes with several kids and a husband and other families. So we'll see. But I've got a couple of other folks from Atlanta. We've got someone from McDonough, Georgia, right around the corner. Anyway, thank you guys so much for logging in. All right. And I am going to introduce our guest and get this conversation and get this chat started. All right. So we've got Dr. Lilyana Amezuca, who is an associate professor of neurology and the fellowship program director at the University of Southern California, Keck School of Medicine. She got her BS degree from the University of California, Irvine, and her medical degree from Jefferson Medical College in Philadelphia, Pennsylvania. She did neurology residency and training at USC, and she also has a Master of Science, which she received from USC. She is an amazing neurologist that does so much for the community, an advocate for decreasing health disparities. She serves on many steering committees, and she's on the Spanish editorial board of the Brain and Life magazine, which is a magazine that is published by the American Academy of Neurology. She also is an amazing researcher. She does so much research, y'all. And she is currently examining the relationship between social determinants of health and healthcare access and utilization in Latinx people with MS. So let's welcome Dr. Amezuca.
Hi, everyone.
All right.
I'm so excited to be here. Thank you, Mitzi, for having me.
Absolutely. Welcome to Brain Chat. Okay, so we are going to chat it up, and this is an extremely important topic, near and dear to your heart as well as mine. And so I'm really excited to talk about this on the show. We've done some episodes where we've talked about MS in the Black community. We've talked about underserved populations, but we have not specifically talked about MS in the Hispanic Latinx community, which is extremely important, not only because there are many people who fall under this umbrella of what we describe as Hispanic Latinx, but there are also many people who are Black who also identify as Hispanic and Latinx. So I think this is extremely important, and I'm ready to get right into it. So why don't we start by you telling us just a little bit about yourself and kind of how you got into this space, Dr.
Yeah,
Amezuca?
sure. Well, I'm Lilyana Amezuca. I myself am Hispanic / Latino X, Latinx individual, first generation here in the United States, and really proud to be, one of them. And certainly, when I started my training, I really was focused on multiple sclerosis and a lot of its biology. But, when you're right there in the clinic and you're seeing the population, I'm here in Los Angeles, and Los Angeles is, as you know, a melting pot. You have about 65% of individuals that, claim, sort of designate themselves as Latino as well. And so you end up seeing a lot of Latinos in our MS specialty clinics. And one of the things that I saw was that, well, I'm seeing them, but yet, the literature says they don't really get MS, maybe 50% less risk, but yet, it seems like I have a lot of them to see, and I don't know what would be the best tools to take care of them. And so certainly that's how it started, sort of this interest in trying to better understand, sort of like it's like, what is known about African Americans with MS? Same thing with Latinos. There was not much back, more than 10 years ago when I looked up the literature, and eventually that's how we ended up connecting.
It is. And that paper that we were a part of, was very eye-opening, right? With the late Dr. Omar Khan, where there were like, 100 and something articles about MS in Black people. And there were like 20 or 25 in MS in the Hispanic Latino population. And of course, you have exponentially increased that with the work that you have done, but there still is a lot of work to do, and I have the same issue. I'm looking at my lobby, I'm seeing people, and the people that I'm seeing are not the people that I learned about in the textbook or learned about in training. And so we have to find a way to kind of bridge that gap and, fix that disconnect so that we can really serve the people that we're seeing on a regular basis.
Absolutely. And I think the word is here, is that there's a lack of, and we want to connect. And that's why we're here, wanting to make connections with you guys and everyone. What's the best way? What would you like to see in your MS care, in your journey with this chronic disease? How could we best serve you?
Absolutely. Now, let's get into this understanding of Hispanic versus Latino versus Latinx. I've even had some of my friends who are Hispanic like, what does Latinx mean? So let's talk about what these terms mean kind of culturally or ethnically, and how do we distinguish those terms, or what group of people are we referring to?
Right. So when we say Hispanic or Latino, so Latino is grabbing anybody of a Latin almost back to linguistic, it's a Latin-based language. So if you want to be all encompassing or, grabbing everyone, you're going to include even Italian, but you shouldn't, right? But the Latino will grab anybody from Latin America. And then the Hispanic, it has an origin of the Spaniards. And so it goes back to that sort of designation. And so over the years, and it came down to a census issue where the United States was trying to determine how many individuals are coming from these regions. And it started, giving the names. And so in research, we tend to sort of slash it because, which term should we use? I think the Latino one is a little bit more of, it's going to be able to grab individuals from Brazil that don't necessarily have a Spanish language. And so, but the most important thing is, what do you as an individual, associate yourself with? And so what it comes down to, and we say it often, it's a social construct. Who do you associate with what name is the best one? Now, Latinx is not necessarily a new word, but it's becoming a little bit more popular. I just recently saw like a poll, I think it was from the Hispanic Pew poll, saying that only about like less than 10% actually associate themselves with Latinx. So it's not yet a very popular one, but I think the X is just saying, it's like, okay, now we're going to be gender non-discriminating, and it's not Latino or Latina, right? Because Spanish language is a lot about, putting a sex to the word, right? And so now you're adding the X. But in any case, I think, from this issue is that it's a complex word to define an individual. And then if we get to the genetic ancestry, right, then you now have this issue of like, oh, we're dealing with ancestral backgrounds from Africa, right, from Europe,
Right.
and from, and then the indigenous or Native American mixture, which sort of gave rise to what a Latino is, if
Mhm.
you want to say that. And then, of course, like you said, there is Latinos that are Black or have a greater, background of African ancestry. And so they
Mhm.
consider they're self-identifying with as Black Latino,
Mhm.
which, in the United States seems like it's about, total of 15% of Latinos, or at least so far, when you pull it. So yeah, so I think it's just a complex, type of designation, but it comes down to what do you want to be referred as, right?
Right. Right.
I don't know how, I mean, maybe it's a little bit same and from, do you prefer African American
Yeah.
or Black
Yeah.
or what, or Black Caribbean? Because we
Yeah.
have that too, right?
Yeah. And I think it's so interesting because one of the difficulties, especially when we talk about things like the clinical trials and the research that we do, is that we often try to force people to check one box, right? So if you think about many of the different the mixed ancestry, right? Which box are they going to choose, right? If someone is mixed race and they are white and Caucasian, white and Black, which box
Mhm.
are they going to choose? The Black box, but how, and if they are also Latino and Black, or Latino and, so I think that we have to find, the best way that we define it right now is what you identify with, but, we have to find more concrete ways to try to make sure that we are, um, encompassing, more than just one box, especially when people identify with several different
I do
backgrounds.
agree with that. I do think so because it's sort of like you said, there's a lot of now mixture between races and ethnicities, and
Hmm.
and the current classification is not getting everybody.
It's
I mean,
not.
we ourselves also, right? We've seen in our studies is like we put them under a bucket of other,
Hmm.
but because, like you said, it's like, well, which one? Did they identify themselves? If they identify with both, what do you do? Uh,
Yeah.
so there has to be better methodology, or we just need to explain the methods that we did and
Hmm.
then say, for the purposes of research, right, which methods we did and use that.
So, speaking of genetics, let's talk a little bit about some of the work that you've done with your registry, with collaborating with Dr. Chinea and others, looking at different Latino, Hispanic populations and kind of their backgrounds and how that may affect different aspects of their MS. For instance, when I think about doing Ancestry, I remember I did Ancestry.com not too long ago, and so this is a sidebar. Many people in the Black community think that they have some type of Indian or Native American background. And my
Mhm.
mother was very disappointed to find out that mine was very, 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 very small, like minuscule. She's like, it's not right. That's not right. Your great great grandmother, So when we break it down to more of a genetic level and not looking at it in terms of like phenotype, what we look like on the outside or what type of
Right.
music we like or grew up with, tell us a little bit about some of that information and how that may affect some of the outcomes that we see with MS in the Hispanic Latino population.
Right. So meaning genetic variation, how did it come to be, right?
Yeah.
At least in the Americas. And so we think about populations that intermixed, right, coming from different regions. So it's
Mhm.
representing, this variation across time, but also across geography. And so, you think about, oh, who left Africa and blah, blah, blah. And that's how you end up, and then coming to the Americas. So when I was thinking about MS, was that, we have a complex disease where so far, all this data has suggested that there always seems to be specific regions in the world where there's less MS, for
Mhm.
example, in Africa. And then there's also protection of these populations if they, perhaps move at a certain time in age, right, to areas where there's high prevalence, or where there's a lot more MS, they develop MS depending on the age. Either they get more propensity to get MS if they're younger, right, when they moved, or maybe they'll still be protected from getting it. So something about them, right, is being protected. So that means that there's probably some genetic aspects to the protection of MS, but also the development. And certainly from, MS in whites, you see, you've learned of certain genes that are important, right, in giving you that risk. And so with that, well, I was thinking, it's like, well, the Latinos are like the perfect, perfect storm of three variations. And, is it the factors that we're seeing in them, meaning presenting with MS at a younger age and presenting perhaps more optic neuritis, which was sort of like this thought that is more of an Asian, phenotype. And so, and knowing also that the Latino of Mexican background has a different variation in their ancestry proportions compared to somebody in Puerto Rico.
Right.
So the Puerto Rican is estimated to have a little bit more African background because of the migration that happened, right, and settlement. And from the Mexicans, it's thought to have a little bit more of the Native American or indigenous background. And so first things that we did was sort of accumulate, right? Try to get as many individuals that wanted to participate and self-identify themselves as Latino or Hispanic. And together with Puerto Rico, Uncle Chinea, who hopefully will come on, and also University of Miami, and also UCSF. So really 4 areas all over the United States. We got about 1,000 individuals to participate.
Wow.
That's probably like the largest Latino, study in MS.
Yeah, absolutely.
Where do you
Amazing.
get over 1,000 patients with all their clinical data and genetic and blood sample?
Yeah, that's amazing.
It was really a big effort. And so we looked at their genetic ancestry, and sure enough, we could see the variations that were expected. You have the Puerto Ricans, like I said, the Mexicans, the Miami background, very similar to what you would expect from those regions. And then we looked at their clinical characteristics, and then we, try to infer if there was a relationship to their genetic ancestry and some of the features that we're seeing. And we did. We found that those that had the highest sort of proportions of Native American had a higher risk of developing optic neuritis. So more Native American, more risk of getting or presenting with optic neuritis with the inflammation in the eye. And the other factor that we saw too is that those that also had more Native American or more African ancestry, their age of starting with MS was younger. It was dropping by 3 to 5 years, depending on what how much of that type of ancestry. So I think that's really interesting. I mean, it's saying there's likely some genetic aspects to how MS behaves. So this is not looking at the risk, but more of like how it behaves, how it's going to, present younger or present later or what. Again, it's just sort of the surface. And so I think, but it also tells us a lot that, that perhaps, if we do more studies in this population, they would be able to participate,
Yeah, absolutely.
Because it's about them.
Absolutely. And so, I was going to ask some different questions, but since we are in this vein, let's stay right here. Thinking about the importance of diversity in research is something that I talk about on almost every show. We talk a lot about diversity in research. We talk a lot about health equity. And so when we think about, you got 1,000 Hispanic Latino patients in the US, and that's with 3 major centers, right? To participate in this study. What types of things did you do to reach the community, or were there different ways or methods that you use to get people to participate? And what was the willingness to participate? Because a lot of times there is this perception that people from, ethnic minority backgrounds or people of the global majority, whatever you want to call it these days, don't want to participate. So how did you get people involved, and what was the outreach to get those types of numbers involved?
Yeah, excellent question. So, going back to it, and again, it's been, over years, right? We had accumulated, everybody had sort of this registry. A registry, as you know, is something simple, is you gather a questionnaire, and then we were just asking for one sample. And at that point, we were promising, it's just one time, you don't have to see us again, right?
Okay.
And at the beginning, it was a lot of convenience. So meaning if I was seeing them, I was there to talk to them about it.
Right.
And so I think it was that relationship I had with my patients, and as well as with Chinea, with his patients, very intimate. I mean, most of these patients that came from my center, and I would say the same for the others, we knew each other, right? And so certainly I think they gained our trust. And so I think that's one thing. Trust, communication was simple. We're not taking, we're making sure, because I think, as you know, Mitzi, and we've done those studies together with the MS Minority Network, is that one of the big things that's still persistent, it's mistrust, right?
Yeah. Absolutely.
And thinking that they're going to get low quality care after participating or while participating.
Right.
So I think that's so important to make note. And so I think it was a lot of almost like holding hands. It's like, hey, it's, we're going to do this, we're going to do that. And then what I've learned afterwards is sort of, they want to participate more. They want to know about other studies and how they can be helpful. And I almost struggle with this part, because I do want to do more, but now we need more funding.
Right. You have to have funding to do research. Absolutely.
Right.
Absolutely.
And I think, and how do you, and continuing to engage the community, just like what you're doing, I think it's so, so important. And I think, there was a lot of good efforts and help, I think, from our partners, from, MSAA, from the National MS Society. But I wish even that we had even more, because I think we haven't erased it. We need more.
Absolutely. Absolutely. So the things I heard: trust, extremely important, right? Also the messenger is important, living in a world where we know that certainly, there are not nearly as many women neurologists as men. And then there definitely are not as many women neurologists or neurologists who are from diverse backgrounds. The messenger who delivers that message and is a part of the community is extremely important. I think the other piece that is extremely important that you brought out is that once people kind of got their foot in the door and participated in that study and saw the benefits, then they often were like, oh man, this is really cool. I want to do this even more. And so I think, again, we have to break those misconceptions, and we have to establish trust, and we have to say, hey, this is helping everyone, and it is important that you were able to look at those different parts of their genetic background, looking at the African part of their genes, looking at the Native American part of their genes, looking at the European part of their genes, and seeing which parts may lead to certain outcomes. I think one of the biggest questions that we have is, when we look at the outcomes that we see, and we'll talk a little bit about this in a few minutes, in Black populations, in Hispanic, Latinx populations, how much of that is caused by genetics, right? How much of it is caused by their background versus how much is caused by social determinants of health and things that are more related to health equity, like not being able to get to the doctor, not having access to an MS specialist, not having access to treatment, being able to get to your, different appointments like physical therapy, because physical therapy costs money, so, we can write all of the scripts that we want. It costs time, usually off work, right? And it costs money every time you go, there's a copay. So again, we prescribe all these things, but we have to look at where people are in the real world and how those other factors in their real world affect their outcomes. So let's talk a little bit about some of the differences that we see in the Hispanic Latino population versus, let's say, the white population, and if there are any similarities that we see between the Hispanic Latino population and the Black population with MS.
Yeah, absolutely. So one of the first things that we see as different is that the Latino, like I said, is younger when they develop multiple sclerosis compared to whites. And they're even much younger if they were born in the United States. So we
Why
have
is that?
immigrant differences. So
Mm-hmm.
meaning, place of birth plays a role in multiple sclerosis, and it seems to play a big role in Latinos as well. So
Mm-hmm.
we're dealing with a little bit of a younger population when you compare them to whites. And then you have similarities in some of, like I said, the predominant feature of presentation seems to be optic neuritis, more so for those that have this Native American.
Mm-hmm.
But perhaps, and we didn't test this well, would the more European background be more typical? Would it be looking like the typical white MS, where
Mm-hmm.
maybe it's more sensory presentation? And
Mm-hmm. So optic neuritis being loss of vision in one eye, the other eye affected vision, and then sensory meaning people have numbness and tingling or
right,
loss of sensation in some part of
exactly.
the body.
Exactly. And
Mhm.
but when you look at outcomes, so meaning, or how much disability they have, how many are using a cane, and you see that, there's a higher proportion of them with higher, more ambulatory disability, in the Latino as well. Always African Americans a bit more, right?
Mhm.
Compared to the whites. And so if you're thinking, well, the Latino presents with them as younger and they still have more disability, that means their disability is at a younger age. So that
Mhm.
means it's going to have a higher effect on their ability to work, right? Their
Mhm.
ability to go to school, their just, what happens, like you said, what are their social conditions before they got disease? And then now that they have the disease and developing in their early 20s and 30s, where are we going to end up? And
Right.
these social determinants of health is where we live, how we grow, where we
Mhm.
die, where everything, right? And
Mhm.
so, and unfortunately, and this is for everything, not just MS, we tend to practice in a bubble, right? We're in
Mhm.
a clinic, we tell them what to do, and then we don't know if it was executed. Oh, we do find out if they went ahead and did it, but we don't necessarily understand why weren't they being compliant, right?
Right. Right.
You said, was it a cost issue or was it something else? I mean, was
Right.
it simply as, the family pressure of saying, oh, that doesn't work, why you take that? Take this herb
Right.
instead, it's
Right.
cheaper, and it cured so many people that I know that have MS. Really? You know a
Mhm.
lot of people that have MS? Yeah. And then you find out it's a different name of the disease.
It's a totally different disease, like,
Right.
you
Like
know,
muscular dystrophy.
yeah, something totally different, yeah,
Right.
and it probably didn't cure that either.
That's right. That's right.
But yeah, so
Right.
true, so true. So again, it's important for us, right? So when we think about health equity, I always, and when we think about increasing diversity in clinical research, there are a lot of moving pieces that need to come together. And there are a lot of us that have a part in improving some of those outcomes. And I think for us as, clinicians, people who see
Mhm.
patients on a regular basis, it's important for us to recognize that when someone doesn't follow through necessarily with a plan, it's not always because they don't want to, right?
Absolutely.
That there are other influences that we can't just write it off like, oh, that person's not compliant. They don't want to take care of their MS. That we have to dig a little bit deeper to see what are some of the challenges that they're having and see if there are ways that we can address those to improve
Right.
their health
Exactly.
outcomes. And then also a lot of people from Hispanic Latino backgrounds as well as Black backgrounds have comorbidities, right? They have other conditions like
That's right.
diabetes, high blood pressure, high cholesterol, and all of those things can affect their overall health as well as their MS.
Yep, that's right. And we just did a study that just got published. We looked at over, I think, close to 400 patients or so with the Latino background, and we looked at their comorbidity. So that second, that other condition with MS. And High proportion of them had high blood pressure, a lot of high blood pressure. And the more uncontrolled it was, the more likely they were going to be disabled. And so that tells you, we also need to do better at making sure they're controlling that comorbidity, that they have a primary care doctor. You know how many times I ask them, so who's your primary care doctor?
I say,
Oh,
you,
I have one.
you, Dr. Amezuca, you, Dr. Williams. I'm like,
Right.
no, I'm not.
Right. So we need to, right. And that's just part of, health literacy too, right? It's like, hey, you need to also have this doctor that looks at as you're growing older, right? What other conditions? And then you also have your MS doctor, me, and you need to tell me too if you have a new diagnosis, right?
Right. And you're taking new medicine. Yeah. And I tell people all the time, I'm like, you do not want Dr. Williams looking in your ear. You do not want me looking for strep throat at the back of your, like, you do not want me doing that. So you need a primary care physician
Yes.
to do those things and to do your regular screenings.
That's
As we get older, as you said, there are different screenings we need to do for women. There are mammograms, there are different levels that need to be checked,
right.
colonoscopies, etc. So you need to stay on top of all of that stuff, because MS is enough. We don't need any other problems that could potentially be prevented on top of the MS.
That's right. That's right.
Yeah. So other things. Now, there was a study that you did that I thought was really profound. I mean, obviously we do a lot of work together. You do a lot of amazing work. But one that I now include in every talk that I give about health equity and MS in the African American population. And that was a study that you did on mortality. Tell us a little bit about what you found in that study, because it really just blew my mind. And really brought to the forefront the gravity of what we're dealing with, right? We're not just dealing with disability, but we're actually also talking about preventing mortality. So tell us a little bit about that study.
So, of course, we wanted to better understand, when we think about all this data says that, having MS tends to lower your mortality, right? You 5 to 15 years younger, depending on which studies. And here we are in the U.S. and we don't have a good mortality, understanding at that time, right? And so, and we have an issue, right? Is because we don't have really good registries to be able to understand how many people are dying from MS.
Right.
But the CDC does capture, at least looking at death certificates, of the causes of death. And from there, we can learn a lot. And so it was the first time accessing this database. And so we wanted to look at, again, how many people are dying of MS as the number one cause, followed by other causes, obviously. But we only reported on MS mortality. And we wanted to understand by age, by gender, but also by race. And so they do capture that. And although the highest numbers of deaths were in the white, when you looked at by sex and by age, we were astonished to find that the rates were highest among Black African American males before age 45.
Wow.
So, and for the female before age 55, much higher, higher than the white. And so that was really, really astonishing. And certainly just for all-cause mortality, usually in the United States, it's the unfortunate truth that Blacks, African Americans are the highest. And so we've seen that in MS as well. And so it should, make us think about, is it then, is it the severity of their disease, but also what is leading them to, die at such younger age? Is it the disease itself? Because, I mean, it was MS as the number one cause, but what is also contributing to that, They're not getting their treatment, higher disability, and then, of course, making sure that, no other conditions that mimic it were in there. But really striking. And so it reminds us, like, just from all-cause mortalities in general in the U.S., the biggest contributors to that is a lot of the social determinants of health, things that are
Mhm.
causing health disparities.
Right.
And what are they in MS, right?
Right.
What
Right.
are they? If we were
Yeah.
to give all our African Americans and Latinos to African Americans the same conditions that whites have in terms of access to MS, in terms of timely diagnosis, right?
Right. That's a
Of
huge issue.
MS, would we see a difference? And I think we
Mhm.
need to question that because, the index of suspicion to give a diagnosis of MS in somebody that is Black or Latino or, or not the white is lower. And
Definitely.
so you already have a higher diagnostic error,
Right. Right.
right?
Yeah, meaning, that people are late to diagnosis because you really have to have a suspicion to diagnose MS, especially depending on the symptoms, because the symptoms are very similar to other conditions, right? Someone
Yep.
can have numbness in an arm, and,
Hmm.
the doctor could say, oh, it was a pinched nerve. And if the
Yep.
symptoms go away in a week or so, if
Right.
you
Things are
don't
going
look at that,
away. You're
yeah.
not
If
going
you
to
don't look at
go.
that MRI of the brain, if
Right.
you don't look at that neck, you won't see the lesions
Right. There's
until
no,
they have that second episode,
that's
which could
right.
be 5 or 10 years later. And all of
Exactly.
that time, they've accumulated symptoms, and they've also accumulated little things over time. I can't believe sometimes some of my 20-something-year-old patients come in and they
Hmm.
say, "Oh, well, I can't remember anything. I just figured I was getting old." And I'm like, "Honey, you're 25. Like, you shouldn't be having
We
memory
shouldn't have.
problems at
Right. Right.
25."
Yeah.
Or they're like, "Oh, I just thought I was clumsy." I'm like, "You shouldn't be falling
Oh,
like for no reason." So a lot of
exactly.
times people blow things off if they
Yeah.
are young and otherwise
Right.
healthy,
Right.
so they're accumulating all that disability, and by the time they're diagnosed,
Yeah.
we're a lot further behind,
Yeah.
the ball,
Yeah.
because nobody had that suspicion to order that MRI.
Exactly. Exactly. I mean, so many times and you've heard this with the African American community, it's like, you can't have MS because, you're Black. And that was something that the doctor said. Well, guess what? I just had a patient today, same thing, that was Latino, and she's gone for over a year, multiple doctors. And, it's like, no, nobody ever said MS.
Wow.
And so again, we have that issue. So our patients or that population doesn't have MS as a possibility, but
Right.
also our doctors don't
Right.
have MS in their differential. And so we
Yeah.
need to also do better there.
Absolutely, absolutely. So as we're kind of getting kind of toward the end of our discussion, let's talk a little bit about what are you excited about. So one of the things that has been, both disheartening and encouraging is that with the advent of the COVID-19 pandemic, there's been this spotlight that's been shined on health disparities. Everybody's talking about health equity. Everybody's talking about health disparities. I'm sure you get invited to a million panels just like I do to talk about these types of topics. And so I have seen a lot of progress and a lot of work being done, and a lot of work being proposed now that there's this light on health disparities. What things are you involved in, or what things are being done in the Hispanic Latino MS community that you're excited about
Yeah.
that can improve health equity and improve outcomes?
Well, I'm really excited, first of all, like you said, that there is a spotlight now for us. We've been doing this now for so many years. We've
I know, I
been
know.
talking to each other. We've
Yes,
been
yes.
sort of, saying it's like there has to be some, resources, more resources for our patients from, literacy, health education. We've been doing that a lot. But now we have a spotlight where perhaps there can be, not just funding, but the actual support.
Yes.
Because in so many cases, it wasn't considered, almost like sexy to do this type of work or
Right.
discourage. It's not science,
Yeah.
but absolutely there is science. You can, build it to better understand mechanisms,
Absolutely.
well, of inflammation. So I'm really excited just from the perspective of obviously, that the registries are growing, that there is ability to, a clinical trial, right, that we're both
Mhm.
involved, that is
Yes.
trying to again understand, the treatment, in this case, ocrelizumab, to see how effective it is in our particular population, both African American and Hispanic Latino. But also, sort of excited that, like you said, there's stakeholders, diverse stakeholders that are ready to pour understanding in the social determinants of health. I'm excited right now. We're doing a project with the Bristol Myers Foundation where, we're trying to better understand social determinants of health as they relate to access to specialty care, right? Being a neurologist, how can we connect them? But then also not just describing it, because I think we have a lot of data that obviously supports there is a health disparity.
Right.
But yeah, we're going to describe it still, but then can we put an intervention? And so we're going to try to, better understand if having a clinical care navigator to connect them to, specialty care and be sort of, their liaison constantly. Liaisons and connections, and could we have better outcomes for them down the road? And so I'm really just excited of the fact that there's the opportunity now, right?
Yeah.
So there's opportunity for more research. There's opportunity for our patients to be more engaged. And then on the other part that I'm working with is that we're trying to better, sort of design the next generation of training for those that want to do health disparity research. And that's some work that I'm doing with the NIH. So that part, I'm just really excited to see that there's a commitment at the national level, at the Institute. And then we need individuals with policy making.
Yes, we definitely need some laws on our side.
Right, we need lobbyists.
Absolutely. And I mean, this is such an exciting time, right? I think that again, there's a lot of work that we have to do, but there is a lot of commitment. I remember being the person at the back of the room and somebody's like, "What topics would you like to talk about?" And I'm like, "Minorities and MS," and everybody's like, "We don't want to talk about that."
Well,
So
it's just that so most people that want to do health disparities has been, us, like the underrepresented minorities, right? Because it's dear to our heart.
Right.
And but we need to see more, even if there are not minorities, right? Everybody needs to know.
Everybody needs to know.
And where do we start? This is in general, we got to start really low at middle school, probably.
Yeah.
Letting our children know that this is important, that what is the health disparity as they're learning science,
right.
And what contributes to that.
Right. Amazing. Well, what we'll do is we'll take a little pause for the cause. If anyone has any questions, please feel free to drop them in the chat. I see some comments. People are saying, that this is interesting information, that it's very informative. And so we're glad that everyone who's logged in is logged in. If you have any questions pertaining to this topic, you can drop them in the chat. But as you said, Lilyana, I'm super excited about much of the work that's being done, the research trials. And I think, again, the important key, as you said, is having not just those of us who are part of these communities and passionate about it because we're part of the community, but having the broader community become involved. And that's all the way from the people in clinic to those who are designing the clinical trials, to those who are funding the different types of research, to those who are, approving these medications. Like, there's a part for all of us to play in improving the system and making the system better. But we definitely recognize that now is the time for intervention, right? So we described it, we talked about it, we talk about it and talk about it, but now we need to make some moves toward changing things and improving the outcomes for everybody living with MS. And when we increase health equity for one group, it improves the overall health of everyone, right? So what if from those genetic studies that we see, we can determine what portions may be related to what symptoms and outcomes that will help everyone with MS, right? Not just people of these backgrounds. And so I think, again, and when we also talk about health disparities, we have, those who live in rural communities. We have other underserved group within the MS community, those over the age of 55, which the older I get, the younger 55 seems. And I think that's That's a completely arbitrary number. It is not old. I don't know why the clinical trials stop at that age. So I think,
Right.
but we have many, many underserved groups.
Yep. Underserved, vulnerable, right. We're
Yes.
talking here about minorities, but there's many that falls outside of race and ethnicity. So
Absolutely, absolutely, absolutely. Well, with that being said, I think I see one question in the chat that talked about improving life with MS. And certainly that's something that we've talked about in several of our chats and podcasts before, and I think, the first thing that everyone should do is talk with their doctor and come up with a good plan to speak, a good plan for their overall health with MS, and recognize that overall health also affects your MS. But coming up with that plan with your healthcare team is extremely important. So I always direct everyone back to their healthcare team to talk about the best things that they need to do to manage their MS. And with that being said, we have wrapped up another amazing brain chat. Thank you so much, Dr. Amezuca,
Thank you for
for
having me.
joining
It's
me.
always a
Yeah,
pleasure talking to
absolutely.
you anytime.
Absolutely. And everyone have a good night. We'll be back in a couple of weeks. Enjoy your Labor Day weekend. And I hope everyone has a wonderful rest of their week. We'll see you in 2 weeks back on Brain Chat. Have a great one.